From liver to coronary artery disease, we have heard people saying the best way to man's heart is through the stomach, but today I'm going to change the gear and say it is from the liver. Now these are the people who have got a fatty liver disease. And the interesting observation, people who have fatty liver disease, is the special techniques to look at the coronary plaque. And you'll be surprised to see the people with type 2 people with fatty liver disease have got high incidence of plaque, and in people who have metabolic syndrome, in addition to that, have a higher incidence of the plaque of coronary artery disease. So all patients put together, you have a high level of coronary plaque in these patients, telling you that the patients with the fatty liver disease have something to do with the coronary artery disease. Now this is the INTERHEART study, which looked at more than 15,000 patients around the same number of controls in 52 countries. And the most important point which contributed to ischemic heart disease was the lipids. The lipids were the most important contributor to the ischemic heart disease in patients who were studied for dyslipidemia in the INTERHEART study. Now what's important is if we look at the function of the liver, the basic function of the liver, the inputs to the liver is carbohydrates, proteins and lipids, and the synthesis of cholesterol occurs in the liver with the acetyl coenzyme A under the influence of HMG coenzyme A. That's how the liver itself produces the cholesterol. The cholesterol de novo is produced in the liver. And when you have a fatty liver, these patients have excess amount of glucose, they have high triglycerides, they have low HDL, and there are many other factors which contribute to ischemic heart disease. We'll quickly go through each of them to prove the point how the liver is important to induce coronary artery disease in a given patient. Now in patients of type 2 diabetes have excess glucose. This excess glucose from the pyruvate produces acetyl coenzyme A. And this acetyl coenzyme A, under the influence of sterol regulator element binding proteins, produces more amount of cholesterol. So it is the input of glucose itself which contributes to the cholesterol pool. Furthermore, when you see these patients who have high calorie intake as a part of the metabolic syndrome and a decreased expenditure, have the positive energy balance. And therefore, because excess fat in the adipose tissue is overflowing with a lot of fat, and that overflow goes into the visceral fat, into the liver, into the myocardium, into the muscle, and into the pancreas. That's how the fat gets distributed into various organs purely as a part of the adaptive mechanism, because of so much of fat is coming into the adipose tissue. Furthermore, the adipose tissue that you see in the center of the abdomen, or what is called visceral abdomen, is larger in size. And because it's large in size, it attracts a lot of macrophages, and therefore this fat is an inflamed adipose tissue which brings about a lot of inflammatory cytokines into circulation, which contributes further to coronary artery disease. So therefore, all these excess fat or ectopic fat is responsible for increased risk of a coronary artery disease. Now if you look at the patients of type 2 diabetes who have got insulin resistance, have a high level of triglyceride. And this is because of the excess amount of ApoC3. And this excess ApoC3 prevents conversion of triglycerides to IDL, and it also prevents uptake of IDL by the LDL receptor. Therefore, the triglycerides tend to accumulate. And furthermore, the lipoprotein lipase enzyme is deficient in type 2 diabetes, and therefore the conversion of triglycerides to IDL is also prevented, and that's why you get a high levels of triglycerides in patients of type 2 diabetes. The excess input of free fatty acids coming from the center of the abdomen or the central obesity is the one which gives you a large amount of free fatty acids because of insulin resistance. And these free fatty acids convert to triglycerides. It's packed with microsomal transfer protein along with ApoB and pushed out into blood as a part of triglyceride excess. So therefore, liver is a basis or is a site which produces large amount of triglycerides in patients of type 2 diabetes. And the same thing is true that this is a macrophage, and from the macrophage the cholesterol is effluxed by the HDL, comes to the liver, and the cholesterol excreted in the bile. But in patients of type 2 diabetes, they have high levels of hepatic lipase, and they have a high levels of CETP. And because of excess CETP, there's siphoning of cholesterol from the HDL to the VLDL. At the same time, this cholesterol becomes ineffective, and that's why the HDL level in patients of type 2 diabetes is less. So you have a high VLDL and a low HDL, which is an important component of diabetes. So therefore, the classical atherogenic lipoprotein triad, which consists of large triglycerides, low HDL, and a small dense LDL, which is a cause of an increased risk of a coronary artery disease in patients of type 2 diabetes. Now, this is a very important study called a Copenhagen General Population Study, which looked at more than 40,000 population in Copenhagen. And if you see the triglyceride levels, as the triglyceride levels start rising, you see very interestingly, the remnant cholesterol also rises. The remnant cholesterol also does penetrate into the endothelium, and after penetrating endothelium, it carries with its cholesterol. And that cholesterol is actually atherogenic. And this large production of remnant from the liver in patients of type 2 diabetes also contributes extensively to coronary artery disease. Now, this is a study which looked at the lipids in the cardiovascular disease. And here we have about 96,000 people studied for a coronary artery disease and the relationship triglycerides. These are non-fasting levels of triglycerides. As you see the rising triglycerides, there's a rising trend of a ischemic heart disease of the hazard ratio of 5.1. And if you furthermore look at the patients of ischemic heart disease, the rising trend of hazard risk of 3.2. So therefore, the rise of triglycerides definitely contributes to ischemic event. In the past, it was believed that triglyceride does not contribute at all to the ischemic heart disease. This is contrary to the fact that about 96,000 patients studied tells you very clearly that the rising triglycerides, which is non-fasting, contributes to the ischemic heart event. Now, these are the meta-analysis of 5 landmark studies, which are more than 4,000 patients, which were studied with the PPAR alpha gamma drug. And it says that those people who have a triglycerides above 200 and HDL below 34 have the decreased risk of the coronary artery disease. But those who have triglycerides up to less than 204 and HDL more than 34 have a decreased risk of a coronary artery disease. So therefore, the point is that those patients with triglycerides are more than 204 and HDL less than 34 have an increased risk of a coronary artery disease when you look triglycerides as a contributor to the ischemic events. Now, this is a very interesting study which looked at the loss of function of ApoC3 as a part of mutation which contributes to ischemic heart disease. Now, ApoC3 mutation are some of the populations seen, and they have a low triglyceride levels, and these are more than 75,000 participants studied for a period of 34 years, and here the non-fasting triglyceride less than 90 and a triglycerides more than 355, and therefore there's a decrease of risk by 60%. So therefore, the ApoC3 reduction itself can bring about reduction of myocardial infarction by 60%. Now, small dense LDL also contributes to the ischemic event, and here you have patients who have got identical LDL levels, but those who have high triglycerides have an increased number of particles of LDL. So high triglycerides indirectly tells you about high levels of small dense LDL contributing to ischemic events. This is a Framingham study which looked at HDL and LDL. And HDL is independent risk factor for coronary events. If you look at the low HDL levels, with a normal LDL level, the ischemic events are higher. So therefore, low HDL is an independent risk factor for coronary events, though it was believed in the past that is always LDL, but low HDL also is very important indicator of a coronary events. Now, besides this, there are additional atherogenic factors from the liver, like oxidative stress, insulin resistance, inflammation, adiponectin, and procoagulant state. Now, here's the inflammation, which comes as a part of the insulin resistance, and therefore the interleukin-6, TNF-alpha, which enter the liver. And the liver produces CRP, which is the acute tissue reactant, and this CRP gets into the vessel, and in the vessel it blocks the production of nitric oxide. And because of reduction of nitric oxide, the vessel undergoes a spasm and further produces interleukin-6 and TNF-alpha, which goes into the liver, and the vicious cycle continues, and that's how we get more and more events, because liver being the site. And there's a Hoorn study which looked at the CRP levels, and the lower the CRP levels, lower is the survival of these patients. Again, Paul telling you that the CVD risk is common with these people who have high levels of CRP. The oxidative stress is very evident, and the oxidative stress causes, of course, endothelial dysfunction, and which is a part of the diabetes problems. Besides that, you have a combination of factors which promote thrombosis and factors which decrease fibrinolysis. Both these factors, for example, the PI1 is basically produced in the endothelium and also produced in placenta. And therefore, these are the one substances which produce more coagulability and therefore causing more coronary events. Now, I want to bring you to a very exciting event, and this is the gut microbiome. Last 5-6 years, we've been seeing the sea change in the analysis and understanding of the gut microbiome contributing to coronary artery disease. And here we have the New England study and a Nature study, which says that the people who consume large amount of fat have these kinds of problems of coronary artery disease, which is mediated not through the liver, but through the microbiome, which brings about chelation of the phosphatidylcholine, which is a content in, for example, egg yolk, or all those kinds of fats. There are 3 kinds of fat. We have triglycerides, we have cholesterol, either plant-derived or the animal-derived, and the phosphatidylcholine, which is broken down by the gut microbiota and produces a toxic substance called trimethylamine, which is actually a toxic gas. And this gas gets oxidized in the liver under the influence of enzyme called FMO. And this produces a substance called TMO, which is a toxic to produce the atherothrombosis. So therefore, when you have a statin therapy given to the patient, which works primarily on the Homo sapien HNG coenzyme A, this part of the problem of atherosclerosis is forgotten. And therefore, this is a new area where we can focus to treat patients of ischemic heart disease. Now, looking at TMO levels with all those hazard ratio, with the myocardial infarction, death and stroke, and MACE, you see the higher the levels of the higher the quartile levels, you see there's a more incidence of ischemic events in patients who got a high TMO level. And this is very interesting, called carnitine, which is actually a transporter of fat into the mitochondria for the beta oxidation. And this carnitine is also abundant in people who eat steak meat. We used to say red meat is good for the body, red meat is good and it is nutritious. But here's the evidence which says that red meat contains large amount of carnitine. And these are the bacteria which break that carnitine part of the substance, produces large amount of TMA, trimethylamine, and which gets into the liver and is flavin-containing microorganisms which oxidize TMO to produce TMO, which produces atherosclerosis. So there's a new area of research or new area of interest for people who want to know how do you understand the management of atherosclerosis besides HNG coenzyme A. So therefore, this can open up a new vista of managing dyslipidemia through the gut microbiota. This is an interesting study which looked at people who were basically carnivorous or who are non-vegetarian versus a vegetarian. And these vegetarians were coaxed to eat this red meat given by way of capsule. And when they're given this kind of meat, they did not have increased amount of TMO because they're vegetarians. And the non-vegetarians, when they're given this kind of a red meat, had a sudden rise of TMO. Again telling you that this kind of substance, the red meat, in the non-vegetarians is responsible for a large amount of the atherosclerotic process which occurs in the coronary arteries. Among the therapy, we have all kinds of weight loss, diet and exercise. And here are the statins, of course, omega-3 fatty acids, PIP agonist, ezetimibe, and we have the new words called gene silencers. Now we have in the liver where the cholesterol is, when the free fatty acids gets into liver, it forms the M protein and forms triglycerides along with ApoB. We have the MTPI inhibitor called lomitapide, and this lomitapide inhibits the combination of the triglyceride along with ApoB and cannot be brought into circulation. So we can block this production of triglyceride. We have two new genes called DJAT1 and DJAT2. These are the genes which produce large amount of triglycerides into liver. You can have a therapy to turn off these genes, DJAT1 and DJAT2. When you turn off these genes, the production of triglycerides from the liver goes off. The very interesting, exciting field is what is called PCSK9 inhibition, which is a very novel way of treating patients of hyperlipidemia, especially who have a familial hypercholesterolemia. You will be no surprised to know when you give statin therapy to any patients, they get reduction of the cholesterol to the tune of 40%. When you double the dose of statin, the further reduction is just 6%. It doesn't go beyond that. What is called a rule of 6. Now, why this should happen? The reason why it happens is when you give statin to these patients, besides inhibiting the HMG coenzyme A to reduce the synthesis of cholesterol, it also upregulates PCSK9. And by upregulating PCSK9, the statin effect is brought down. So you can get a ceiling effect to the statin when you keep on increasing the dose beyond the certain limit. And that's why there is a ceiling effect. And this PCSK9, what it does is, it gets attached to the LDL. And once the LDL is internalized by the liver, in the liver, the receptor is separated and is brought to the surface of the liver to pick up more LDL. And the LDL, which is brought inside the liver, is internalized and broken down, is either lost in the bile as a cholesterol. Now, what happens when you have excess PCSK9? This releasing of receptor doesn't take place. And therefore, you get less and less number of receptors. And therefore, you do not have enough amount of receptors to pick up LDL from the circulation to reduce the LDL level in the blood. And the monoclonal antibody, which when given to PCSK9, which can again go outside the liver, can also help to reduce these patients' cholesterol level. So these are the new insights. And besides that, the CETP inhibitors, I think the subsequent speakers will speak on this. And the DELA, of course, has lost its place in 2012 because of its side effects. The EVA and anacetrapib might come in 2016, 2017, maybe a new therapy to manage patients of diabetes with dyslipidemia. So therefore, ladies and gentlemen, to carry home the message, we know that HDL is a good cholesterol. There is no doubt about it. We know LDL is bad. But what we should remember, or what we should understand today, is that the remnant is equally bad. In fact, it's ugly. So you need to attend this. You need to have attention focused on this to manage patients with diabetes, because this remnant does penetrate the endothelium and carries with it cholesterol, and therefore is atherogenic, and we need to pay attention to that. With these words, thank you very much for patience here.